Welcome. My name is Dr. Mellon. I'm a psychiatrist in Texas. This is a video that's going to go over sleep-wake disorders from a psychiatrist point of view. So if that is interesting to you, then you are in the right place. So we're going to talk about sleep physiology, the major neurotransmitters of sleep, circadian rhythm, the homeostatic control system, and then we're going to talk about a highly simplified scheme for wakefulness and sleep, and then we'll go over DSM sleep-wake disorder diagnostics, and then medications used to treat insomnia. So first big take-home point is to be aware is that being awake is an active process. Being asleep is an active process. So it's not your brain's running and really active, and you go to sleep and it's not really active. Both sides are active processes. Wakefulness and sleep are run by homeostatic drives, circadian rhythm, and neural networks. It's not one thing runs anything. Being drowsy is a state of diminished vigilance. So it's used as a concept for a transition period of the brain from wakefulness to sleep. Sleep and wakefulness is maintained by non-localized processes. You need to think, when it comes to behaviors for organisms, especially people, you need to always think of it as being more of like neural network circuits. It's not localized. Sleep is broken into two segments. We have the rapid eye movement and non-rapid eye movement sections. So non-REM and REM. Non-REM is broken into three stages, 1, 2, and 3. So the neural controls of wakefulness, the major systems are going to be these five: the ARAS, VLPO, orexin system, circadian controls, and homeostatic controls. We're going to just briefly run through each of them. So ARAS used to just be called the reticular activating system, is now referred to the ascending reticular activating system. It is a set of neurons that affects the four main monoaminergic pathways. So norepinephrine affects through the locus coeruleus neurons. Serotonin, it's affecting through the raphe nucleus neurons, its interactions with them. And the dopamine, it's affecting through the ventral tegmental area neurons. And then the histaminergic neurons from the tuberomammillary nucleus are all being affected by ARAS. So ARAS affects norepinephrine, serotonin, dopamine, and histamine to generally promote wakefulness in a very, we say complicated, complex way, and that's just because basic pathophysiology is not known yet. All right, the VLPO is the ventrolateral preoptic area. It's mainly producing GABA ergic neurons it's affecting, and then a neuropeptide called galanin. So both of those, GABA and galanin, are trying to inhibit neuron firing. So they promote wakefulness often by inhibiting the other neurons that are being affected by ARAS plus orexin. So like histamine is a big thing that promotes wakefulness in the brain. So to promote sleep, VLPOs through like GABA will be inhibiting the TMN histamine neurons. Every one of the VLPO neurons has orexin, so it also inhibits those neurons when it wants to try to promote sleep, because orexin being activated is what promotes wakefulness. And then it affects just subsections of the serotonin, norepinephrine, and acetylcholine neurons. So orexin originates, these neurons, this quote system, originates in the hypothalamus and then projects widely across the brain. Effectively innervates all components of ARAS. The circadian controls, this is the concept of a cyclical biological activity. So you think the day-night cycle or seasons for animals, things of that nature. Although melatonin is the most well-known in this process, it's really, there's other major aspects like the circadian genes, they're referred to as like clock genes, that create the circadian rhythms, and they're basically ubiquitous in the brain cells and probably every cell in all living things, and across kingdoms, and fungus and stuff. So kind of a cyclical pattern for all living things probably is to some degree affected by ideas like things like the clock gene network. The simple standard melatonin regulation story that's always given is basically there's this idea of it's an eyeball to pituitary gland pathway. It's called the retinohypothalamic pathway. So you have environmental light, hits the melanopsin pigment expressing retinal ganglion cells, so special cells in the ganglia, capture light in the environment. Then they're going to have a pathway that stimulates the circadian control rhythm, which is in the suprachiasmatic nucleus of the hypothalamus, referred to the SCN. And then the SCN leads to the pineal gland releasing melatonin. So you end up with this pathway where you go from light to the retinal ganglion cells to the SCN to the pineal gland to melatonin release. Although that pathway is pretty well mapped out now, seems to be consistent, seems to be well documented and understood. The actual next step of what does endogenous melatonin do, what are the physiological effects, actually not well understood. So this is where it's easy to feel like we know a lot when we don't. Homeostatic controls, the take home here is just basically that it's been known for a long time, but not a lot of folks still realize, is that sleep regulation of sleep has been running off of a model for 40 years, of this idea that there is the kind of the chronotropic aspects to it, the circadian rhythm, and then there's a homeostatic control systems that basically build up over biological substrates and aspects like adenosine. They build up over time while you're awake, and they build up more and more, and it causes more and more sleep pressure, more and more diminished vigilance and arousal, trying to push the organism into sleep. So there's been a lot of good animal models that have demonstrated that extracellular adenosine suppresses wake-promoting neurons and excites sleep-promoting neurons. So adenosine can be considered a big factor for being able to fall asleep. And if you take naps during the middle of the day, you're going to clear out a lot of the extracellular adenosine in the brain that's used for this purpose and make it harder to fall asleep later because you're not going to be as tired. So here is the highly simplified scheme of wakefulness. So remember, wakefulness is an active process. You have histamine and orexin neurons are just widely projected across the brain and promoting brain wakefulness. So histamine promotes wakefulness, orexin promotes wakefulness. Circadian rhythm and homeostatic control systems slowly increase sleep pressure to reduce arousal and vigilance as the day goes on. The ARAS, which is made up of those nuclei that are in the midbrain, pons, and medulla that are in the image on the bottom right. They have widespread projections that go to the cortex, thalamus, and the hypothalamus using those monoaminergic systems. So dopamine, norepinephrine, serotonin, histamine. Also hits acetylcholine receptors and glutamate. So it uses all those things to promote wakefulness. And we know that if you get a bilateral lesion of the, more or less just of the midbrain around where the RAS was first identified, we know that we can induce coma in people. I think people used to think of it as being an aspect of consciousness, or maybe an on-off switch for that. So sleep is an active process. So sleep is created and maintained by the VLPO, homeostatic sleep pressure, and the circadian rhythm. So you notice we go back a step. It's not histamine or orexin, and it's not ARAS. Those are promoting wakefulness. Sleep is promoted by the VLPO, the homeostatic sleep pressure, and the circadian rhythm. The VLPO is is a set of neurons that are nuclei that is located in the anterior, the forward towards the face of the person, of the hypothalamus. So it's just above the pituitary gland and definitely below the thalamus. It's just above the optic chiasma. This is the brain's sleep-promoting nuclei that has the projections across the brain, like we said. It's using GABA and galanin to inhibit ARAS, so it can promote sleep. It's using, it affects serotonin, norepinephrine, dopamine, histamine, orexin. Its functions, the most important ones initially, are basically inhibiting histamine, because that's one of the two major systems keep you awake. Histamine and orexin keep you awake. It also inhibits the hypothalamic orexin neurons, so there's the other half. And then there's also a bunch of other, this is just as an example, specialized neural pathways, nuclei, whatever you want to say, that it are also affected. So there's actually REM on and REM off neurons as well that help promote those cycles. And so the VLPO inhibits REM off. So it's inhibiting its ability to turn off. So it's by doing that, it's promoting REM, which is a part of sleep, which is what it's trying to promote. So some of the fast features you're supposed to know for non-REM and REM. Basically, these are just things that a lot of information has been studied and known, because when you put stickies on people's heads for electrical activity through EEGs, you can record a lot of information, and then just research has been done trying to figure out what that information means over time, just like when you did EKGs initially, and then figuring out what each aspect of the QRS and stuff meant. So based on EEGs, there's this division of non-REM and REM. Non-REM is controlled by a more localized network. It's basically just deeper structures of the brain, with the thalamus or thalamic nuclei having a large part of the pathways. And so it's seen as being a little bit more localized. REM is seen as a much more diffuse network without a lot of locality to it. Non-REM was originally divided into 4 steps, because they had this idea of deep sleep and slow wave sleep when they first did this back in the 1960s. In 2007, so a long time ago, over 15 plus years ago, the American Academy of Sleep Medicine went ahead and combined stage 3 and 4 into a single stage and just said stage 3. So non-REM for quite a while now only has 3 stages. Non-REM is driven by the VLPO, it's used through those inhibitory neurotransmitters, GABA and galanin, and it promotes the sleep cycle by inhibiting those wakefulness neurons from orexin and ARAS. So when you fall asleep, you typically start in non-REM. It's atypical to fall asleep and quickly go into REM. It's usually more of a sign of disease states. Non-REM brain electrical pattern looks nothing like wakefulness, because the electrical activity predominates in the hypothalamus and thalamus. So the EEG electrical activity doesn't look anything like the person's awake. Many actions are downregulated during non-REM, including cortisol, thyroid hormone, respiratory rate, heart rate, blood pressure. Don't memorize any of those. Just know that a lot of aspects of physiology are actually changed during REM and non-REM. Some functions are also increased. Here's a bunch of items. So things like prolactin, insulin, testosterone, growth hormone, right? General anesthetics, when they induce a person to sleep and it's kind of like a transient coma, it resembles non-REM sleep electrophysiologically. So when you're looking at an EEG, there's just some kind of characteristic aspects to it, so how they divided and define them. So stage 1 of non-REM, it's a slow cycling. So it's 3 to 7 cycles per second. That means if you take 1 second time strip, you'll end up with waves 3 to 7 times. And they're referred to as theta waves versus based on basically physical characteristics of the EEG strip of the amplitude and width. Stage 2 is twice as fast, so it's a 12 to 14 cycles per second. It's got 2 definable patterns that occur during stage 2. So they described one or named it as being a K complex, and another one as being sleep spindles. Stage 3 is very slow, significantly slower than everything else. Hence, it was slow wave sleep is kind of how they were looking at it. You can refer to as delta waves with that have kind of large amplitude, 75 microvolts. The spindles and of stage 2 and the delta waves of stage 3 are thought to be due to like this loss of the cortex oscillations due to suppression by like ARAS and the histamines, histaminergic neurons, and then switching over to a synchronous firing of the thalamocortical network. So it's just this idea that as the brain is actively trying to switch between stages and sets and then processes, it can cause these kind of like a little bit more synchronous firing that creates something other than just a generic continuous wave. REM, rapid eye movement sleep, typically occurs about 90 minutes after sleep. It's characterized by brain activity when you're doing the EEG that basically looks like wakefulness. So it's because overall the brain really has similar electrical activity, cerebral blood flow, glucose metabolism, things of that nature. You have generalized muscle atonia during REM, other than the eyes and diaphragm and like penile clitoral stuff that'll be on the next slide. And that's why it's called rapid eye movement. Your eyes move, but basically the rest of your body's not. Obviously, you don't stop breathing and die. So whenever you're trying to figure out for like sexual dysfunction or things of that nature with psychiatry and doing some like the tape tests and stuff, this is the phase where clitoral penile tumescence would occur, and you'd be able to, engorgement is all that means, and that would let you know that it's if a person is still able to get an erection, but they're saying they can't during the day, it might be more stress related or maybe medications or something of that nature. The threshold for arousal is higher in non-REM than REM. So people are harder to wake up when they're in non-REM and they're really groggy. When you're in REM, typically you can wake people up a little bit faster, they're a little more alert, more quickly. So here's an example of what REM would look like on the right. You just have these random, fast, low voltage kind of sawtooth waves, which is pretty similar to being awake, which is the left one. So the major neurotransmitters that are part of sleep-wake physiology are basically ones we've already talked about, and we'll just talk about a little more detail now. So norepinephrine, right, it's primarily initiated from the locus coeruleus. It's a subset of both norepinephrine and serotonin together will inhibit REM sleep, so that's a way that they affect it. It's not typically a target for medication. Some people, note sedation with things like venlafaxine, but it's not typically a side effect of affecting serotonin or norepinephrine systems. It's more of just required for the control, like overall process. High norepinephrine, though, can increase wakefulness and inhibit sedation. So, just think adrenaline. If there's a lot of it, it can inhibit your ability to be sedated. And that's more of a common adverse effect of the SNRIs. So serotonin from the Rafe nucleus is where those originate from. Just like norepinephrine, not a common target, not a common side effect for sleep. Paroxetine is the one you might pop in your head going, I know that one can be sedating, but that's actually because it's more anticholinergic, not because of the SSRI aspect. Dopamine, so dopamine originates from the ventral tegmental area neurons. It's also not a typical target for medications. It's not a common effect either of those medications. So if you're thinking of an antipsychotic as being sedating, again, it's because of other things. So if you think of olanzapine, it's because it's anticholinergic. Same kind of stories for quetiapine and other medications. Histamine comes primarily from the tuberomammillary nucleus, spreads throughout the brain widely, and especially the cortex. Blocking histamine is a drug target, and it does induce sedation. So the first generation antihistamines that were created, like diphenhydramine, those do cross the blood-brain barrier, and they can be sedating for a lot of people. But as you know, some people, they get a paradoxical effect, like with kids, and you give it to 1 in 10, and 1 in 10 actually is more awake, and it has no effect on. And the neurodegeneration of this, like second generation, etc., the antihistamines don't cross the blood-brain barriers so that they don't induce this sedation effect. GABA. So let's correct this slide. There we go. GABA is a typical insomnia target for medication, so the GABAergic pathways are important for initiating sleep through the VLPO system. Benzodiazepine and Z drugs are a primary example. Alpha-2 delta, so this is not the most common target for medications to cause sedation. Some doctors, despite this, still do this as like a second or third degree kind of option, or third line option rather. Realistically, they kind of reduce people's anxiety like temporarily, same way kind of like benzos would do, and not through the same mechanism of action or anything, but some people can find that sedating. So gabapentin, pregabalin could be used that way. Gabapentin typically more than pregabalin. So there's the orexin-containing neurons. So these definitely are, it's orexin and histaminergic neurons are the two primary systems, neurotransmitter systems that promote wakefulness. So the orexin neurons originate from the lateral hypothalamic neurons, and sleep-inducing pathways of the brains are going to try to inhibit those neurons, and destruction of those neurons actually is the primary cause of narcolepsy. So we do have medications. This is a common target. Melatonin from the pineal gland. So it helps entrain the brain's circadian rhythm for the day-night cycle. There's actually two receptors. There's the melatonin 1 and melatonin 2 receptors. There's many drugs, not many, but there's about 3, that started with Ramelteon back in 2005, and there's been a few other melatonin agonists since then. M1, M2 is just this thing where the eyeball has more M1. Once you get to the suprachiasmatic nucleus, it's like an M1, M2 split, kind of more even. Alpha adrenergic 1 can be used. Alpha 1 could be used as a target for things to do with sleep-wake disorders, but not to cause sedation. Prazosin is an alpha 1 inverse agonist, and it's used to reduce nightmares. So it affects the sleep state, but not inducing insomnia, sedation. You could also have an alpha adrenergic 2 agonist. So this is more of a children thing than adults. Really not a first line by any means for adults. So it's like guanfacine and clonidine can be used this way. So I think that's good enough for trying to understand basic physiology. More stuff keeps getting figured out about physiology over time, but like the state of knowledge to practice, kind of bench to clinic, kind of research to practical application. Other than the new medications coming out like Ramelteon and stuff, or like the dual orexin receptor antagonist, things of that nature, just knowing that that's a system and the drugs treat it, that's good enough. There's not a lot of else of the physiology that's particularly helpful yet. So the DSM, this is a pretty chunky section. There are 17 sleep-wake disorders. It looks awful, looks scary, so we're going to just start knocking out pieces of this till it's kind of more manageable and what we do in psychiatry. So if we take this middle section, right, we have central sleep apnea, obstructive sleep apnea / hypopnea, it's OSA, narcolepsy, and sleep-related hypoventilation. These really aren't psychiatry treatments that exists in the book, but this is more of go get a sleep study. This is a sleep specialist is going to treat you, not us. I'm not ordering, CPAP and a mask for patients as a psychiatrist. Central sleep apnea, the kind of big buzz concepts, terms you should know as a psychiatrist, so you can read paperwork and forms from the sleep specialists when the patients get their sleep studies. They're doing polysomnographs. They need to have evidence of 5 apneas per hour. What an apnea is, a cessation of breath, varies whether it's considered an adult or a child. A child just means they have some kind of respiratory rate average, and then they miss 2 breaths in a row. That's good enough to call it an apnea. You need 5 of those per hour. For an adult, it's cessation of breath for 10 seconds. So you need 5 of those. So obstructive sleep apnea, OSA, you just need, so this is a central sleep apnea, so it just means that you're not breathing because the brain's not telling you to breathe. An obstructive sleep apnea is more because you're just or they like to say dumb terms like redundant tissues and things, like made up words trying to make people feel better, but that just due to like body habitus and the buildup of tissue that in the throat and stuff can actually cause people to not be able to breathe, kind of just from the normal musculature physiology, and so then they end up getting an obstructive sleep apnea. It's still the 5 apneas per hour, same as central sleep apnea. So narcolepsy is just this thing where a person, at least for 3 months, 3 times a week, they fall asleep spontaneously, and then they need evidence of one of these additional pieces, either catalepsy, which is just whenever you have kind of a strong emotion, and then they go atonic immediately. So basically, like the person laughs or does something like that, and then they immediately fall asleep. You can check the CSF and get hypocretin levels is another option, and so all you need is less than 110 picograms per milliliter from the CSF, and that is diagnostic as well as one of the pieces. Or you just get polysomnograph evidence, so basically you capture them falling asleep, and they basically, instead of going to non-REM and having a 90-minute gap and then going to REM, they just go straight to REM. It's mostly caused by autoimmune destruction of the brain's orexin-containing neurons in the lateral hypothalamus. So it's pretty much that's it. That's the common case. That's what you're going to see when you destroy all the orexin cells, kind of like getting islets of Langerhans cells destroyed for insulin, pancreatic cells getting destroyed for diabetes type 1. Then you just have a downstream problem. So you destroy the orexin neurons, you end up with narcolepsy. It can't, because orexins are promoting wakefulness, and then they can't really maintain and manage that system in a normative manner. So you have just an abnormal network firing, and the person just instantly falls asleep. Sleep-related hypoventilation. This is just where you get polysomnographic evidence of periods of reduced respirations with increased CO2, but it's not due to apneas. So now we're down to 13. So let's talk. There is a chunk of unspecified disorders. So these really don't matter. As a psychiatrist, never diagnose, from my point of view, never diagnose an unspecified disorder. This is for either pretty much ER doctors or doctors that actually don't want to, or I guess know how to make some of the diagnostics for the DSM for psychiatry, which is fine. For psychiatry, you shouldn't do this. You shouldn't just put, I don't know what it is. I just, I think there's a sleep problem. That's kind of all you're saying here. It's not helpful. So now we're down to 10 disorders. So there's the other specified. So these are the diagnostic space holders. So this is what we can use instead of unspecified. So if you have evidence of one of the disorders, but not enough to make the final diagnostic, you put in this diagnosis. So you say other specified insomnia disorder, or other specified sleep-wake disorder, and then you put a reasoning for it, like, pending, getting a polysomnographic evidence or whatever you need. This gets us down to 7. So the DSM, we're getting towards things we actually treat and we particularly care about in psychiatry. So there is the REM and non-REM sleep disorders. The first one, it's non-REM sleep arousal, like waking up and moving disorders. So you end up with non-REM typically is that one where you said where it happens first before REM, and it's a deeper sleep, it's harder to wake up from. So in non-REM sleep arousal disorder, you have this incomplete arousal from sleep. The eyes are open. They can have like sleepwalking behaviors or night terrors, last up to maybe 10 minutes, and then they go back to sleep. It's really hard to wake these people up. They don't remember what happened during that event. They don't even know what the dream was. They don't know anything. The most typical version of this is night terrors, and that is a small child, 3, 4, 5-year-old, who, the parents are asleep, they hear screaming, you walk over, you see a child standing in a hallway, their eyes are open, and they're just terrified, and they're yelling and screaming, and the parents are getting all distressed, trying to help the child. They're like shaking him, they don't wake up, they're sitting him with them for a while, the kid finally wakes up or just goes to sleep. And then the parents talk to him in the morning, and they have no idea what's going on. They weren't scared. They have no nightmares that they can recall, and they're just freaking out the parents. So you just naturally grow out of it. It's pretty common. REM sleep behavior disorder is whenever you start to have complicated motor behaviors or vocalizations while you're asleep during REM. So it's not right when you fall asleep, but usually much later, an hour and a half, 2-3 hours after you go to sleep. When you wake up a person who's doing these things like walking around in their sleep sex behavior, sleep eating behavior, all these kind of things, then they quickly wake up, they see what's going on, they understand what's going on, they might just be embarrassed in that kind of situation. You can get polysomnographic evidence, and person is acting out their dreams and punching their husband or wife or whatever and flailing, and they're have like bad trauma history and everything's going bad or whatever, that you'll see them on a camera that they're asleep. The EEG shows they're asleep, but they're physically they're not atonic. Unfortunately, this is one of those things that if they have REM sleep behavior, we need to go ahead and start looking for evidence of synucleopathy. So people, it's very common if they have like dementia, Lewy body dementia, multiple system atrophy, things of that nature, that they're the ones who they lose their atonia and start moving and acting out in their sleep. It's also REM sleep behavior is like a 50-year-old, kind of 60-year-old, 70-year-old sleep-wake disorder versus like non-REM is a young person's onset. So if they're 3, 5, 10, 20, you're probably not looking at a REM sleep behavior disorder. You're looking at a non-REM sleep arousal disorder. All right, we're down to 5. Progress. Nightmare disorder. All right. So recurrent, vivid, distressing dreams with no abnormal sleep behaviors. And you become oriented very quickly on waking up. Bad dreams, they bother you. You're not moving while you're dreaming. Like you can roll over, that's fine. You're not like punching and walking around. The typical treatments when we're doing the pill pushing is prazosin, topiramate. It's kind of this back and forth argument over time with evidence which one actually works better. Used to always be prazosin. Now people argue it's topiramate. You just kind of start low, go slow, see if it helps. Topiramate has an easier dosing strategy. Prazosin obviously affects blood pressure and has a much larger dosing range. And you can actually, though, if people have nightmares, when it's like trauma, it's repeating nightmares, really, really bothersome, image rehearsal therapy probably works as well or better than any of the medication options. It's kind of like you're talking about writing and then changing the ending to the horror of that nightmare and prepping it every night before you go to sleep. And it does a good job in breaking this. All right, we're down to 4 sleep-wake behaviors or disorders. RLS, restless leg disorder. This is one of those things where you can go to MedCalc, click on the 5 answers from like a sheet, and you've made a diagnosis. That's all it is. So it's an unpleasant feeling in the legs, creating a need to move with them. You have the urge to move the legs worsens during inactivity, and at least is partially relieved by moving those legs. And the urge to move legs, it only happens at night. It's not restless leg syndrome happening during the day. It needs to be going on at least 3 nights a week for 3 months. So causes are all over the place. Fibromyalgia, neuropathies, iron deficiency. If they have iron deficiency, then great. That might be an easy way to find it. But pregnancy, it can happen, but don't treat it if it's due to pregnancy. They just have to be uncomfortable and finish going through their pregnancy, have the baby, it goes away. Major organ dysfunctions like renal failure can do it. Alcohol, nicotine, and caffeine can cause it. So if they're on those things, you can tell them to stop, see if it stops. There are reports of it being caused by medications like SSRIs, SNRIs, TCAs, diphenhydramine, antipsychotics. I kind of question that. I think it's probably more of a case study scenario and not an actual side effect. So treatment, if they have low iron, you just give them iron supplements along with ascorbic acid, vitamin C, because that promotes absorption of iron. Non-pharmacological treatments for kind of anybody, and particularly the primary treatment when it comes to pregnant folks is going to be stretching, avoid caffeine and nicotine. You can do a warm bath before bed. The typical first-line treatments are dopamine agonists. It's pramipexole and ropinirole. Sorry about that noise. Second line options are going to be your alpha-2 delta ligands, the gabapentin, pregabalin. So you kind of have four drugs you just immediately use. It's pramipexole, ropinirole for the dopamine agonist, and then you flip over to gabapentin, pregabalin. All right, we're down to 3. substance medication-induced sleep disorder. So, indication of a sleep disturbance in a setting of recent drug use or withdrawal. The drug must be known to cause insomnia or capable of causing anxiety. So they're drinking, they're smoking pot, they're doing whatever, and it's been weeks, from that time frame, a month or two, you can still call it. Some things, can have very long, prolonged sleep disturbances. So alcohol and meth can do that. Like for alcohol, you drink really heavy for years, you stop, maybe it's 6 months or 12 months before your sleep kind of goes back to normal. Sleep-wake disorders. We are down to circadian rhythm sleep-wake disorder. All right. So it just means a pattern of sleep disruption characterized by day-night cycle of patient, not matching the circadian rhythm, leading to sleepiness or insomnia. So when they want to be awake and when they want to be asleep is not matching what their body is doing. So this is broken into 50 types. This is a lot of ink wasted for not a lot of benefit, but basically the ideas are you're falling asleep, you're getting really tired and trying to fall asleep, at 5 in the afternoon, 6, so you have an advanced sleep phase type, or you're trying to fall asleep at midnight because you're a typical teenager because you naturally have a delayed sleep phase type. It's irregular sleep wake type, which means you don't know the answer. Probably the patient history is not good enough. It's a non-24-hour sleep-wake type because humans actually within like 15-20 minute time frame of 24 hours is our day-night cycle. The circadian rhythm clock is really good. And there are situations, disorders where it's not a 24-hour sleep-wake type. Like I think that happens particularly with like people that are blind, things of that nature. And then it can be a shift work type, which is nonsense. It just really means that you're flipping your day-night cycles and then you're not sleeping well because you're trying not to be on a consistent day-night cycle. Which finally gets us to the most generic answer, which is what we do for a living often, is the insomnia disorders in psychiatry. Just means general dissatisfaction with sleep, time length, or the quality with any of the following. You just need one. So they're not happy with their sleep, how long they're asleep, or how good that sleep is. So very generic, very simple. And they either have difficulty falling asleep, so sleep onset insomnia. They're waking up multiple times at night with difficulties falling back asleep. So it's sleep maintenance insomnia is what sleep specialists often refer to it as. And then early morning awakening and unable to fall back asleep. So it's the classic depression statement is one of the options. So to be an insomnia disorder, it should be for 3 months and at least 3 times a week. Let me get some coffee. So you're probably staring at this going, oh my gosh, too much text. I just put it here for completion. Basically, the APA's point of view, the American Psychiatric Association, is that if you are treating a patient with medications for insomnia, you can put insomnia disorder. That allows us to bill. That gets us from a 3 to a 4 more easily. So you could have major depression. Known problem is insomnia as part of the diagnostics. If you're just treating the depression without treating insomnia, then you don't need to put insomnia disorder. But if they have major depression and then you're treating their insomnia, then you can also add insomnia disorder, and that is fine. So medication targets for sleep that we use. So acetylcholine is one. Acetylcholine has M1 through 5 receptors. It's M for muscarinic because that was a compound from a fungus that they found would react to nervous system. That's basically it. Nothing fancier than that. So acetylcholine binds to 2 types of receptors, the muscarinic or the brain ones we care about. We use acetylcholine esterase, the things that break it down, acetylcholine inhibitors, ACHIs, so that affect M1. So commonly learned acetylcholine nuclei in psychiatry is in the basal forebrain. It's called the basalis of Maynard. It is the smaller, so there's 2 circles in the central part of the brain. It's the one a little bit higher up. There are actually more. Each of those circles is another pathway for acetylcholine. So whenever we learn things that are like, we say the VTA is this one thing, there's more than that one system, but that's the primary. And so acetylcholine goes all throughout the brain from that basal forebrain area. Acetylcholine promotes arousal, alertness. It promotes REM sleep. So it promotes you being awake, but also once you're asleep, acetylcholine promotes the REM portion and not non-REM. It helps for memory and kind of general plasticity of the brain. So when you antagonize the M1 receptor, You end up with people getting sedated or drowsy. Whenever a person's anxious, we use a euphemism in psychiatry, say it's calming, but it's sedating. Acetylcholine from the M1 blockade can lead to confusion, constipation, dry mouth, urinary retention, and blurred vision. So not our favorite thing for geriatrics patients or patients with benign prostate hypertrophy or any of that kind of stuff. So this is just, I'm going to flip through these slides quickly as we get to them. It's just for a case in point. So there are different types of drugs bind to different affinities, and with these are just numbers that are adjusted in average for teaching purposes. But some of the drugs that we use, we'll say they are like anticholinergic, and some of them are much, quote, stronger than others. So things like amitriptyline is 10 times more sedating in regards to the M1 receptor than quetiapine, that kind of thing. The confusion point there is realistically that these medications hit more than one receptor often, and the dosing is different with these medications. So if you're taking 400 milligrams of quetiapine, that's very different than taking 25 milligrams of amitriptyline. So even though amitriptyline is stronger, and it's 10 times stronger, well, but you're taking 30 times as much quetiapine. Adenosine is an important aspect of sleep. So adenosine, there's at least 4 receptors. Maybe we'll find more in the future. If you look on the right and you get trauma from undergraduate, you're like, oh my gosh, adenosine. I remember that thing. That's part of like this ATP, and it's also part of like nucleic acids. Correct. There you go. ACTG back in the day, right? Adenosine, extracellular adenosine, inhibits the acetylcholine neurons of the basal forebrain and histamine. So some of the wakefulness promoting aspects, it'll inhibit those. And throughout the day, as we move forward, adenosine extracellularly in the brain increases. When you're asleep, it decreases. So it's been done in like animal studies and stuff. Thought processes, glial cells probably are managing it potentially in that clearing out process and that ability to have that sleep pressure build up through adenosine. So higher adenosine correlates with a stronger feeling of sleepiness. This idea of sleep pressure. Adenosine increases in non-REM stage 3, the slow sleep wave stages. So if you have a lot of adenosine build up in your body, the stage 3 slow wave sleep is longer. The only thing maybe as a better take-home point is CBTI, cognitive behavioral therapy, Insomnia, utilizes the idea of adenosine when it does sleep restriction or sleep deprivation, however you want to look at it. So it's keeping people awake, no naps, and reducing the amount of time they're asleep at night, their sleep window. And as you shrink it down more and more, adenosine will build up more and more, and that sleep pressure should get more and more. More. There you go. So an adenosine promotes sleep, the adenosine receptors. So the antagonist promotes wakefulness. And the primary adenosine receptor antagonist is, drum roll, caffeine. So that is what caffeine does. It's also hit by marijuana through THC. Alcohol can do it, propofol, and maybe there's some evidence for some TCAs as well. Dopamine promotes wakefulness through ARAS and the nucleus accumbens. The nucleus accumbens, primarily, it's because dopamine promotes excitement and arousal stimulation, so that promotes wakefulness. We pretty much, though, for medication purposes, when we talked about RLS, restless leg syndrome, we're using ropinirole and pramipexole as a way to treat that disorder, and not necessarily to be awake or to be asleep, but to reduce the urge and discomfort with restless leg syndrome. Alpha-1 antagonism. So the CNS alpha-1 antagonism causes vasodilation of the brain. Neurotransmitters, norepinephrine has a higher affinity to alpha-1 than the hormone epinephrine. So norepinephrine has a stronger affinity for alpha-1 in the brain. When you antagonize that vasodilation, norepinephrine binding alpha-1 receptor antagonisms, when you inhibit that process, you end up with more sedation. So alpha-1 antagonism that is capable of crossing the blood-brain barrier will cause more sedation. It can also cause, like, the part that doesn't cross the blood-brain barrier and stuff can cause like dizziness and orthostatic hypotension or headaches for the brain. Prazosin is the drug of choice here, and it doesn't actually promote people falling asleep, not super sedating, so it's mostly just has an abnormal effect that inhibits either having nightmares or processing or registering that they have nightmares, right? Because you can have somebody screaming and scary because they have night terrors through the sleep cycle disorder, sleep-wake disorder, and but the child doesn't remember at all. It doesn't bother them. So, fun fact, when I was researching this stuff, is prazosin at one point was tried to use as a male anti-contraceptive. Because there was another one that was an irreversible, non-selective alpha blocker that was believed to block alpha-1 receptor at the vas deferens, leading to a reversible sterility. Be kind of cool if that would have been an option at some point. But when they tried prazosin as a male contraceptive pill, it did not produce the same effect. So apparently it has to be non-reversible for that to work. And the non-reversible had lots of side effects, so we don't do it. All right. Antipsychotics can be sedating through alpha-1 antagonism. So chlorpromazine is a lot of this, and it works its way down to olanzapine being a little bit, and haloperidol is in the middle. I got to sneeze. Sorry. TCAs can also be kind of middle of the pack here. So amitriptyline and nortriptyline are particularly sedating TCAs, and this is part of the reasoning. Histamine. There are 5 receptors. The histamine originates from the TMN, the tuberomammillary nucleus, which is in the hypothalamus. Of those things, we only care about H1 for this purpose. So we have H1 inhibitors, antagonists, and agonists. The VLPO uses H1 to promote wakefulness. If you antagonize it, it can inhibit wakefulness. If you want to look at it that way, promote sleepiness. H1 antagonism causes sedation. It also causes dizziness, blurred visions, headache, ringing of the ears, tinnitus. It is associated with weight gain, increased appetite, and then nausea, vomiting, constipation, diarrhea, so all sorts of GI effects. So diphenhydramine and hydroxyzine are the two probably best and well known in this area. But if you look at mirtazapine, it has about 80% blockade at 15 milligrams, which the typical dosing for sedation for mirtazapine is 7.5 and 15 milligrams. And it is actually quite a bit stronger at H1 antagonism than hydroxyzine is. Quetiapine is about equivalent to that, to the diphenhydramine hydroxyzine angle, and olanzapine is a little bit stronger in between. So here's another random fun factoid that the TMN, those histaminergic neurons, were identified because there was antibody targeting that was done, and when they were trying to figure out what these receptors were in 1984, and when they lit up the brain with those antibodies and imaged it, they said, ta-da, there is the TMN. There is a primary location of where histaminergic neurons are coming from. Melatonin, so circadian rhythm is entrained by melatonin. There's the M1, M2, like I said earlier, melatonin 1, MT1 is primarily in the retina, MT1 and 2 are in the suprachiasmatic nucleus, which then leads to the pineal gland to release its melatonin. Melatonin release is delayed as we hit kind of puberty and adolescence to early adulthood. So we say it's a delayed sleep phase shift. So instead of wanting to fall asleep at 9, you want to fall asleep at 11, basically. So I'm not sure that this stuff helps a lot, but when I was just trying to look at these different things and trying to see if there was anything useful or helpful out of it, it's easy in psychiatry for things to feel like Me Too drugs. So melatonin, Ramelteon, and Tasimelteon are all M1, M2 agonists. So they promote melatonin, and they have a slightly different ratios. That Tasimelteon has a much heavier shift towards the eyeball, and MT1 in the suprachiasmatic nucleus, and the other ones are shifted more towards MT2 and not the eyeball. So for whatever that's worth, I don't know. I don't think anybody knows. Orexin, previously called hypocretin. Orexin A and B are the neuropeptides. The receptors are referred to as OX1 and OX2. So orexin 1, orexin 2, those are the receptors. The neuropeptides are orexin A and orexin B. So again, orexin neurons are located in the lateral hypothalamus. They regulate wakefulness along with histamine. They're big promoters of wakefulness, and the VLPO will inhibit orexin neurons so that it can get you to go to sleep. Orexin is one of the new kids on the block. It was discovered in 1998 at UT Southwestern in the Dallas area. It was for the Greek word for hunger. Now you're like, wait, I thought it had to do with sleep. And it does, but it also has to do with appetite quite a bit. Injecting orexin A or B into the cerebral ventricles caused the animals to eat a lot. So that's why they called it orexin or hunger. So it can be used for sleep onset and maintenance. It's expensive. Theoretical abuse potential, it's probably questionable, to be determined. But it can be used for any aspect of sleep right now. They have two of them are pretty much Me Too drugs. That would be the suvorexant, daridorexant. Limborexant has a very different ratio. Instead of being like 1 to 2, 1.5 to 2 type thing, it's 16 to 1. So there's at least a difference. This is a take-home point for narcolepsy, is the hypothalamic disorder usually is autoimmune that causes destruction of the lateral hypothalamic orexin neurons. This is not a random disorder. It's not just people being weird. It is an actual autoimmune disorder. Psychiatry loves thinking about types of patients based on side effect profiles and trying to pick a good patient based on more than one factor. So we can do things like say that if you have headaches, migraines, and you have problems falling asleep, then amitriptyline, nortriptyline might be good because it's kind of two birds, one stone, can help reduce headache severity and frequency, and it can help you fall asleep. If you're depressed, type idea, then with insomnia, then something like mirtazapine particularly can be a good option if you're using it as a single pill choice, because it both treats major depressive disorder and sleep onset insomnia particularly. But it can increase hunger. So if they have depression with weight loss or something like that, mirtazapine becomes a good choice. Quetiapine theoretically could be there. When people have sleep-wake shift problems, then obviously melatonin and trying to maybe pick a stable day-night cycle can be important. I'm actually not going to focus on this stuff too much. I just want to talk about the drugs a little bit. So just screenshot, here's some slides. It's not worth talking about in painful detail, but the drug tables are important in this process because that's what we do for a living. So clonidine is typically a drug that does 0.1 to 0.3 milligrams a day. This is really a child thing more than adult. If you stop it and you're taking 0.3 milligrams every day for weeks and weeks and months, you stop it, you're going to cause rebound tachycardia. That you can give quetiapine. It's hitting H1 and 5-HT2A receptors. This can go as high as 200 milligrams. The thing you got to be really careful about is this is a second-line treatment because it causes lots of weight gains. It really does put people to sleep pretty well, but it also causes a lot of rebound insomnia if they try to stop. You can hit alpha-2 with H1 and 5-HT2A, so everything above when you use mirtazapine, amitriptyline, and nortriptyline. The TCAs, amitriptyline, nortriptyline, when you're using them at the lower dosing, say 25-50 milligrams, I wouldn't really consider or concern myself with them being on SSRIs or anything of that nature because they kind of sequentially will hit different receptors to different degrees, and primarily this is more of a sedative and not an SSRI at those low doses. So, and they work pretty well for that purpose. If they had no suicidality and you didn't care if they're on TCAs and they didn't sleep well, then it could just be considered a first-line treatment for them and it would be fine. Mirtazapine is only considered a sedative at the 7.5 to 15 milligrams. Typical dosings for depression would be 30 and 45. I would not at all ever try to think of it past 15 as really being a sedative. If you really wanted to pretend, maybe say 30 milligrams, but definitely not 45. It's going to cause appetite increase, which can make it a bad drug. The GABA A drugs, These are the Z drugs. These are all very good drugs, considered first line by sleep medicine. Psychiatry is scared of them. General medicine in the United States keeps thinking about them as addiction potential. Seems very bizarre that I would, take Zolpidem, Ambien type thing, and pass out for sleep, and then wake up, shove another one in my face real quick just to keep sleeping. It's not. These are terrible abuse drugs because they put you to sleep. If you try to stay awake on them, you can become psychotic. People have really strange behavior when they sleep pretty often, so that's not trivial. People walk around and have non-REM sleep-wake behavior, walking, eating, doing sleep sex, those things, and don't remember any of it. The one thing to know about this group is, and you have to learn in more detail, really over time, but as zopiclone is a special place, it's a 1, 2, 3 milligram drug. It puts black box warning all over the bottle. It says you need to be in bed when you take this drug because you might just pass out and hit the floor. It is a very, very short onset, very short lasting benzo for GABA A. The DORA, dual orexin receptor agonists, suvorexant, lemborexant, daridorexant. These are the new drugs on the block. They have very simple dosing strategies. They work for all versions of sleep. They're horrible if the person has narcolepsy. If the person has narcolepsy, they should be treated by a sleep specialist anyways, and not you. And these are expensive. H1 antagonists can be used. Doxepin is a real medication, can be used for a prolonged period of time, 10 to 20 milligrams, typically just easy dosing range. Uses to be a 6 milligram tablet. There's no point in that. It's expensive. There's no difference at 4 milligrams that matters. Doxepin's a TCA, so it could be prescribed at 1, 2, 300 milligrams. You don't have to worry about those other side effect profiles. It's an H1 blocker at that first 10 to 20 milligrams. Hydroxyzine and diphenhydramine are kind of very, you have intermittent insomnia, not particularly great. If you use it 2 days out of the week, fine. Try to use it 7 days out of the week. It probably won't work at all. Very common one in psychiatry is the 5-HT2A alpha 1 H1 inhibitor set up with trazodone. It is a medication commonly used from 50 to 200. Heroic dosing goes up to 300. Most people, it's effective at 50 to 150 milligrams. The priapism concerns, things like that. This medication back in the 80s was prescribed at 800 milligrams to be a serotonergic drug, and it had additional side effect profiles, including problems with priapism. I have never seen that, although I have heard, anecdotally, it's still happening. If you have a city with 200,000 people, that you'll get 2 or 3 cases in a year that are thought to be related to trazodone, and they end up at the ER, and it has to be worked on by the other doctors to fix. So could happen. Warn your patients. Calcium channel blocker, gabapentin, can be sedating. It's definitely not first line. Basically, it's just if you have a lot of anxiety at night and that's causing you problems falling asleep, gabapentin might help you. Other than that, it isn't a particularly good sedative. And then you have the 3 melatonin medications. You have regular melatonin, Ramelteon, Tasimelteon. This is a weird space for me still. Melatonin is not FDA approved. There's no right dose for it. We don't know. The little take 3, 4, 5 milligrams dosing is 10 to 50x what a normal physiologic level is. So, and then once you get to Ramelteon, Tasimelteon, it's 8x of that. So major super therapeutic dosing to what the brain does and needs, and is reported to help folks with insomnia disorder, although cost is an issue right now. Herbal supplements, basically, from my standpoint, is no evidence, but there are folklores and people still do these things. So you have chamomile, and there's no real dosing or anything, and no studies have ever really supported, and it's just a pain. You really just need to know the adverse effects that you would care about. So chamomile, maybe if it helps you sleep, great. If they have ragweed allergies, it might cross-react. Kava is just more of a case study, theoretical risk of hepatotoxicity. Valerian extracts, some people kind of, when I was finding papers and through my books, would say up to maybe 900 milligrams at night could be done. L-tryptophan, this is something that was done for, they say, hey, it's in turkey meat. It's just as much in basically all other meats that we eat as well, for cow, pig, turkey, chicken. So it's not really different. It was never a real story. People believe it, eat a lot, you get tired, it's normal. And when you look at this stuff online, there might be, instead of being 500 milligrams of the dose, they'll give you 3,000 milligrams and stuff. So it is what it is. So I'm going to skip these two. All right. So hopefully that was helpful. That's me, Andrew Mellon, and signing out. Take care.